Hello and welcome to another live Google Hangout. I'm Dr. Jay Harness, Medical Director Answers. And once again, we have a really timely subject to discuss today. We're going to be talking about estrogen hormone replacement therapy after a woman has had a hysterectomy. And it's with real pleasure that I welcome a friend and a distinguished colleague, Dr. Philip Sarrel. Dr. Sarrel is Emeritus Professor of Obstetrics and Gynecology and Psychiatry at Yale. Phil, welcome to Breast Cancer Answers Live Google Hangout.
Thank you very much for inviting me, Jay. I understand how important your program has been, and it's a pleasure to be part of it.
Well, thanks very much. Phil, you and I have been working, but you're the driving force behind the creation of a foundation called Advancing Health After Hysterectomy. Maybe you can share with our audience a little bit about your driving interest in this, the new foundation that you're the president of and have been the driving force behind. And we want to talk about breaking news when it comes to estrogen hormone replacement therapy after hysterectomy. Phil, please take the lead.
Well, in a sense, Jay, our idea begins with the publication in the Journal of the AMA in 2011 of a very important paper from the Women's Health Initiative. That's our national study of hormone replacement after menopause. In the 2011 paper, they reported the findings for women who had had a hysterectomy who were just given estrogen compared with placebo. And those women were actively treated for 6 years and then monitored for another 5 years. The end result of that was that the women who received estrogen only compared to placebo, regardless of their age, all the way from age 50 to age 80, all of the women showed a reduced risk for developing breast cancer. It was reduced by more than 20%, and it was consistent with the literature for estrogen-only treatment. The study also showed, which was very important, that for women who were age 50 to 59, who received estrogen only after their hysterectomy, there was a reduction in myocardial infarcts, in heart attacks, and a reduction in death. And that's, in a sense, the bottom line. That if the women took estrogen, it reduced mortality. And subsequent to that, colleagues of mine at Yale, from the School of Public Health, epidemiologist guys, worked with me, and we published a paper in the American Journal of Public Health based on the findings of the Women's Health Initiative. And the reason we did that is that in this last 10 years, there's been a terrible confusion, not only among the general public, but among the media and among doctors themselves, a confusion about the different hormones that a woman's body naturally makes. Estrogen is the most important, but what's happened since the first publications of the Women's Health Initiative, and those had to do with women who had a uterus who received a totally different treatment than estrogen only, what's happened is everyone has become fearful of using any kind of hormone. And there's been a major problem of which we called estrogen avoidance. We did a calculation for our paper, and we said women being afraid of using hormones has led to a decline of millions of women who should be using it. And if those women had been using it, lives would have been saved, mostly by preventing heart attacks, but also preventing death from breast cancer. Remember, and I should make this point, in the Women's Health Initiative, if the women received estrogen, the reduction in mortality due to breast cancer was reduced by 63% if you took estrogen. So what we did was calculate how many women had died, almost 50,000, because of confusion and misunderstanding that estrogen is beneficial, whereas the other treatment used for women who had a uterus was harmful. We have no argument with that. But we want to support the Women's Health Initiative findings that are so positive and so critical for saving women's lives.
So, Phil, let me interrupt right at this point. That's a beautiful, beautiful lead into all this. You're absolutely correct. When the initial report came out, the number of women on combined estrogen and progesterone hormone replacement therapy for menopausal symptoms took a nosedive. And I think you're absolutely right about the fear that's gone on here. I have been saying for the past several years that the culprit in potentially increasing the risk of breast cancer is actually the hormone progesterone. And if a woman still has her uterus in place, she needs the progesterone, and you can explain this better than I can, so that the lining of the uterus doesn't overgrow. Is that a fair summary?
That's correct. And there are early findings back in the 1970s that for women who had a uterus, who just took estrogen and did not take any progesterone, there was an increase in bleeding problems, in the development of hyperplasia, overgrowth of cells lining the uterus, and after an average of about 7 years of unopposed estrogen, an increase in cancer of the lining of the uterus. And then it was shown if you just added progesterone to that, you would avoid that problem altogether. Of course, for the women who have had a hysterectomy, there is no risk of estrogen overstimulating the lining of the uterus because the uterus is gone. So that's taken out of the calculation, which then leaves us with this cohort of women. I should mention there are about 15 million women in the United States under the age of 60 who have no uterus who would benefit from estrogen alone. But there's something else, there's a little twist to what you just said, and I think it's important to highlight. You said progesterone. Progesterone is what a woman's body naturally makes. It's called progesterone because it's the hormone of pregnancy. That's what it means. But in fact, progesterone itself has never been implicated in an increased risk for breast cancer or heart attacks. What has been implicated is the progesterone-like molecule that was used in the Women's Health Initiative study. And that is called medroxyprogesterone acetate, or MPA, or Provera. It has lots of names. And that actually is a molecule that we have known for about 50 years or 60 years, induces the growth of breast cancer cells, not natural progesterone.
Now, Phil, let me interrupt you for a second because you really hit on something extremely important here. I'm a breast cancer surgeon, and I obviously see women who come to my practice who have been on combined therapy. But then I've got women telling me, oh, no, I take compounded natural hormone replacement therapy. And I've often thought to myself, is there really a difference? And maybe you can help clear this right now. With the compounding labs that are out there making up, hormone replacement, is it really all the same stuff, or is there really a natural progesterone that women can get and can safely take?
There is a natural progesterone that has been approved by the Food and Drug Administration. It is a preparation that meets all of the criteria for quality and reproduction and constant testing. What is being marketed to women, unfortunately, is one of the negative fallouts, I believe, of the misunderstanding about hormone therapy. Because what's being marketed is, quotes, bioidentical hormones or natural hormones. The problem is none of these products have met FDA criteria for safety or efficacy. So in fact, you're dealing in the dark when you're dealing with any of those products. If we stick with our FDA and we stay with what they test, what they approve, then we're on safe grounds. But once
Wow.
you go outside, you go outside of that, then I think we're dealing with something where women are being taken in, and it's expensive, and we have no data for safety or efficacy. I think it's an abusive practice.
Well, Phil Sarrel, excuse me, this is really breaking news. This has helped me tremendously because, again, I have people coming in talking about, as you said, bioidentical and all of this stuff, and I've just said to myself, wow, I wonder what's really going on here, if it's safe, and you've really clarified it. That in and of itself in today's Hangout is huge news that we need to be sharing with people. Anything you want to elaborate further on that particular subject, Phil, before we get back to how are we going to climb this mountain of negativity about estrogen replacement therapy after hysterectomy?
Well, Jay, I think you really hit it on the head, because you and I could talk about the facts of the matter. Facts of the matter are that estrogen controls symptoms, it reduces disease like cardiovascular disease and heart attacks, it prevents hip fractures and osteoporosis, it protects sexual function and the health of the bladder and the vagina, does all sorts of good things for a woman's body. We could talk about that all day, but if the mindset is that estrogen is evil or estrogen is bad, that's a very difficult mindset in which it's difficult for people to even hear us. And part of the challenge that we have been facing as a faculty, you mentioned our foundation, the Advancing Health After Hysterectomy. The aim, of course, is to promote dialogue such as ours to help people start to rethink the difference between hormonal treatments. We know that women who've had a hysterectomy have an increased risk for heart attacks, increased risk for hip fracture. They have an increased risk for being hospitalized for suicide attempts if they don't have the estrogen replaced. And all of that is essentially eliminated if you just replace the hormone that is missing because of the surgical procedure. Now, that's not to say that women who have a natural menopause don't face similar issues, but the issues are much more exaggerated in women who have had a hysterectomy.
Now, Phil, there may be some of our breast cancer patients watching today's Hangout who, in fact, are on anti-hormone therapy because of their breast cancer. They're either taking tamoxifen or an aromatase inhibitor, and their eyes may be popping out of their head right now because they're thinking, oh my gosh, because I'm starving my body of estrogen, I've now increased my risk of dying of a heart attack or the other things that you've talked about. How do we strike a balance point here in the treatment of breast cancer where, in fact, we are giving anti-hormone therapy, and we know from clinical trials that does prolong survival? How do we balance all this out, Phil?
Okay. Well, fortunately, Jay, I had the good luck in preparing for today's meeting to watch the meeting that you had with Dr. Knudsen back in February, and in which he talked about immunotherapy and different mechanisms through which the people who are developing new treatments for breast cancer are approaching the whole issue. And you remember that he mentioned a very important action of treatments, and that is, he used the word apoptosis. I know it's a complicated word, but he explained it very well. It simply means inducing the death of the breast cancer cell instead of its overgrowing. And that was a very exciting program. I want to pick up where he left off, because we have increasing information about the value of estrogen in inducing apoptosis of breast cancer cells. Let's go over that for a moment. In February, of this year in the Journal of the National Cancer Institute, there is a very important small paper on using estrogen after treatment with tamoxifen. That would be very important for your patients to hear. It's the use of estrogen after treatment with aromatase inhibitors. Essentially, the biologists tell us that after a period of time in which patients with breast cancer have received treatment that deprives cells of any kind of estrogen stimulus, the cells that remain will eventually become insensitive to the aromatase inhibitor or to the tamoxifen, whether it's at 5 years or 10 years. And that's the moment when adding estrogen induces the death of the cells. That's pretty exciting. Now, what we can tie together, just for one more moment, is what we were saying a moment ago about progesterone. Because remember, the bad actor in the Women's Health Initiative study, in the women who had a uterus who received the medroxyprogesterone acetate, it turns out on a cell level of all the different kinds of progesterone, medroxyprogesterone acetate is the one that blocks the action of estrogen that induces the death of a breast cancer cell. So our molecular biologist friends and colleagues, they've been working very hard these past decades to figure it all out and get it just right. That's why you see, in a case, let's say like Angelina Jolie, where here's a woman who's got all the genetic predisposition for developing breast cancer and ovarian cancer, and look at the heroics that she goes through. She must have received the best advice in the world. And what she did was, she had her breasts removed, she had her ovaries removed, and she put on an estrogen patch. And those doctors knew exactly what the literature has to teach us, that this is the way that woman will be alive. She's only 39 years old now. She'll be alive 30 years from now and continuing to take care of not only her kids but her grandchildren, because they understand the difference between hormonal treatments. That's pretty exciting.
Yep, it sure is, Phil. Well, as we begin to sort of wrap this up a little bit, the points you were making a minute ago about the paper from the National Cancer Institute, in the clinical setting, what we're going to have to do is figure out where the right timing would be to restart if, in fact, estrogen and maybe progesterone with it. In the Petri dish, a lot of this stuff can be seen very easily. Translating that, obviously, to the clinical settings, going to take trials and other kinds of things. Your point about Angelina Jolie is well taken. I would love to meet her someday and thank her for all the wonderful things that she's done. As you know, Phil, we now talk about the Angelina Jolie effect out there, that she's really shined a spotlight on the whole issue of gene positivity, preventative mastectomies, and as you just highlighted, estrogen hormone replacement. Now, Phil, as we wrap this up, are there advocacy groups that you're working with right now to try and get the word out in women who have had hysterectomies about the importance of having estrogen replacement?
That's really right on target, Jay. Last week I talked to the New England OBGYN Society about this subject. In September, the North American Menopause Society will have an entire plenary session about the importance of estrogen therapy after hysterectomy. On September 25th at Yale, we're going to be doing a 6-hour continuing medical education course on estrogen for the primary prevention of cardiovascular disease in women. We can't just address these issues to healthcare providers. The information has to get to the women themselves and also, of course, to the media. There is a website which you know very well because we have both worked with them, and that's the Empower website. that comes out of Scottsdale. My wife and I have been working closely with the Empower website to bring that up to date on all the most recent information, and in particular on estrogen replacement after hysterectomy. They even have an analysis of a paper I published last month on how expensive it is for women to not bring hot flashes under control. We studied just 250,000 women with hot flashes and 250,000 without hot flashes who worked for Fortune 500 companies, and in 12 months, the women who had untreated hot flashes had a medical bill $337 million greater than the women who didn't have hot flashes. They were matched for everything else. And from a healthcare point of view, the women with untreated hot flashes had 1.5 million extra visits compared to the women whose hot flashes were brought under control. So there are lots of issues like that, and Empower, which is a really wonderful women's outreach site, is doing that. Hot Flash Havoc is also an excellent group. Red Hot Mamas is an excellent site. So we have been working with all the women's sites that we feel could bring this information up to date.
Wow, that's fantastic. And just for our audience, that's empower.com, EMPOWHER.com. Phil Sarrel and I are privileged to be on their medical advisory board at empower.com, and it is a wonderful source of health information for women with all aspects of women's health issues. Well, Dr. Philip Sarrel, I would really like to take the opportunity to thank you. My dear friend, you are a walking encyclopedia on this subject, and it's great to have you here. We're going to have you back again in the future, Phil, particularly as there's more breaking news on this subject. I think we're going to have to keep beating this drum about the importance of estrogen hormone replacement in women who have had hysterectomies. Phil, any final thoughts that you have before we wrap up?
No, just to say how much I appreciate the opportunity and also how much you're doing to help women. Thank you.
Well, thank you. And so our friends out there over the social media, this is Dr. Jay Harness. Please have a wonderful day. Thank you for the privilege of your time. We'll see you again at another live Google Hangout.